We're going to look at some diseases where the mechanics of moving free urine are disruptive. You're going to find that urologic conditions can range from being acute to chronic, and it has an impact on us in that it affects our fluids, our electrolyte balances, the way that we handle nitrogenous waste, and even our blood pressure. Life-threatening complications are considered rare with urinary problems. However, patients may have functional, physical, and psychosocial changes that can alter and even reduce the quality of life. This is how we're going to move through today's lesson. I'm going to begin with a pre-quiz assessment. There's about 4 or 3 questions that you will take. I do recommend pausing as soon as you see the question. To pause a PowerPoint when it's in presenter mode, you just have to use the right-click button on your mouse and select the option that says pause. And then you can do the same to resume it, because I'm not going to wait for students to read, because some students read faster than others. So you will need to pause before I click through to the next question. We're going to begin after the pre-quiz assessment, reviewing the system, urinary system, some of the risk factors, how to look at the data, how to prevent and manage some of the urinary infections that can occur, and we're going to discuss what are going to be the benefits of fluid and drug therapy, and last but not least, how to reduce the psychological impact. There is going to be a post-quiz, so I hope you pay attention. Here is our first question. Don't forget to pause it, because now I'm going to click forward. Here's our answers. Between 64 and 100 ounces of fluid should be taken daily to dilute bacteria and prevent infection. Not completing the course of antibiotics could suppress the bacteria, but it wouldn't destroy all the bacteria. This causes the infection to resurface and possibly be resistant. For persistent symptoms of infection, the patient should contact the provider. The perineal area should always be cleansed from front to back, or as we say, clean to dirty, to prevent infection. Cystitis produces suprapubic symptoms. Now, flake pain occurs with infection or inflammation of the kidney. We call that pyelonephritis. Here's your next question. I hope you select the pause button, because I am going to move forward. Here's your answer. Dysuria, the definition of dysuria means difficult or painful urination. Enuresis is another word for bedwetting. Nocturia means frequent urinating at night. Urgency means having the urgency to urinate quickly. Polyuria, as you may remember from the diabetes lecture, means increased amounts of urine production. And lastly, frequency. These are symptoms of UTI, the ones that are highlighted. Let's see if you can get this question. Please pause again. Did you get this answer? Douching is not a healthy behavior because it removes beneficial organisms as well as the harmful ones. Cranberry products consumed greater than 4 weeks have been shown to be effective. This produces a biofilm inside the bladder which reduces bacteria's ability to attach itself. Avoiding carbonated beverages is not necessary to reduce the risk for cystitis. We do encourage patients to decrease carbonated beverages intake if they have a current infection, though. Avoiding fluids after 8 p.m. would help prevent nocturia, but not cystitis. It is recommended that patients with incontinence problems limit their late night fluid intake to 120 mL. This is not an issue with incontinence. Here is an overview of the urinary system. Urethritis, cystitis, prostatitis, pyelonephritis. Every single area of the urinary system can be inflamed independently or with another system. And it all means inflammation of the urinary tract at that specific location. Although infection is the #1 cause of it, we use these terms to describe infectious and non-infectious inflammatory processes. I want you to think of the urinary tract as 2 separate urinary tracts. We have the upper and the lower. The lower UTI'S, or urinary tract infections, are defined as cystitis, urethritis, and prostatitis. The upper UTI'S are just pyelonephritis. What do you think the #1 cause of cystitis is? I honestly would like to know what you think. How about you write it down and then click to the next slide? I'll be waiting. I think I'm done waiting. Whoa! Look at all those causes. Did you write this one down? Bacteria is the most common reason for patients to get cystitis. Officially, we would call it infectious cystitis. Do you know which bacteria patients will test positive for in 90% of the infection cystitis cases? Write it down and let's see if we have the same answer. It is E. coli. Now, where does this pathogen come from? Oh my goodness, you are so smart. I was going to say from the Tom Thumb toilet seat too. Well, actually, that's what my mom told me at least. Did your mom ever make you lay toilet paper down over the seat? Yeah? Because my mom never told me to do that. I might do that to this day, actually. Anyway, right, E. coli, right. This is a bowel pathogen. So how does it get from one body orifice to another? What did you put? Did you write it down? Did you even answer? Are you even listening? Well, here are some contributing factors. Small urine volume, infrequent voiding, sex, wipe direction, which is probably what I assumed you might have written down. Instrumentation, such as maybe when we insert a catheter or a patient goes in for cystoscopy. How about when a patient has a urinary tract obstruction, maybe from scars or previous kidney stones or current kidney stones? Maybe E. coli can get in there because the use of the catheter that is in there is not draining very well and urine is stagnant. Another reason is vesicoureteral reflux. This is where the ureters actually, and even the urethra, don't expel urine, rather than it kind of cycles right back into the bladder. These are examples of what can help organisms migrate upward into the urinary tract. Urinary catheters hold the highest risk factor in patients developing infections. Specifically, we call urinary catheter infections CAUTI's. That stands for catheter-associated urinary tract infection. Your responsibility should be on the reduction of use and the duration of use. Strict attention is needed when inserting to sterile technique. And we need to hang it below the level of the patient, like below the level of the bladder, onto the bed. Frequent peri-care, once every shift. Well, what about paraplegics or people who have BPH? How do they reduce the CAUTI risk? Well, we know that they can't do sterile technique at home. and that is correct. In home, we do use intermittent catheters. They use the clean technique only, but their catheters are not indwelling, and that makes a huge difference. We do see UTIs in these populations though, so good education is helpful. Now, looking at the rest of this list, I bet you're wondering, why is drugs, GYN cancer, radiation, and lupus on the list for causing cystitis? Well, remember, cystitis officially just means inflammation of the bladder. Let me talk about a few of these different reasons. Can you find fungal UTIs? Such as the Candida? Maybe you found it. This can occur because of long-term antibiotic therapy. We also can have fungal UTIs from severely immunosuppression, such as when a patient is receiving chemotherapy. Maybe they have a transplanted organ. Maybe they have Crohn's disease or rheumatoid arthritis. A patient could also be on steroids. Maybe they have diabetes. AIDS patients as well have lowered immune system and are at risk for getting fungal UTIs. How about that parasitic UTI? This is considered rare, and it's because it's transferred from another body site. Trichomonas is a vaginal infection and can be found in urine. We have come to learn that if we treat the vaginal infection, it subsequently treats the UTI. Radiation is also on this list. Radiation therapy unfortunately can cause radiation cystitis to the nearby organs. Occasionally this will happen if a female is getting radiation to her cervix or maybe to the colon, and the bladder is nearby, and therefore it will develop radiation cystitis. Drugs such as Cytoxin or cyclophosphamide that we learned for our last exam, this can cause a type of cystitis known as hemorrhagic cystitis. Do you remember what medication we were supposed to give with it? Correct, we give Mesna. Now, interstitial cystitis is a type of cystitis where inflammation of the bladder occurs, but with no known cause. If we were to test our patient for a urinalysis, it will actually be negative for bacteria. We will have all the signs and symptoms of a UTI. The patient will have pelvic pain with bladder filling or even with voiding. The whole lower urinary tract is involved. It is actually going to occur 10 times more frequently in women. And we will talk a little bit more about interstitial cystitis in just a little bit. Oh yes. Specifically talking about infectious cystitis, I want us to think of two types of infectious cystitis. There's the complicated and the uncomplicated. Well, what goes in the uncomplicated UTIs? Good question. We are going to classify UTIs as uncomplicated if maybe the patient is just premenopausal, they're a non-pregnant female, or they're just sexually active and come in for a UTI. Maybe they got a UTI from douching. But if we go into their history, we understand that there are no anatomic or functional abnormalities, and there's no major comorbidity that the patient has, and we're going to treat it pretty casually. It's a low risk UTI. For complicated UTI, we are worried about these because there is a high risk for treatment failure. There are high risk for serious outcomes. It requires greater vigilance on the healthcare provider's part, and we oftentimes need a longer course of antibiotics. Some of the risk associated with complicated UTIs, or some of the patients at risk for this, is if the patient has an obstruction. Maybe the patient is pregnant In fact, pregnant women need prompt and aggressive treatment because if their UTI can migrate up to the kidneys, causing pyelonephritis, it can actually lead to early labor and early delivery of the baby. Our male genders, males who are advanced age, reason being is they have prostate disease, so their risk for complicated UTIs is higher. Patients who have diabetes, maybe those who have neurogenic bladder, patients who have renal insufficiency, that urine is concentrated and probably more toward the alkaline pH, and this promotes the growth of the urinary bacteria. And lastly, anybody who has immunosuppression. Another way I want you to think of complicated and uncomplicated UTIs is these are considered, I'm pointing to the right, low-risk UTIs, and the one on the left, high-risk UTIs. Did I say that right? The one on the right, let me get my mouse. Here we go. Yeah. Low-risk UTIs, high-risk UTIs. That's better. Well, the doctor leaves the patient's room, and then you come in to hang the antibiotics, and a family member asks you, hey nurse, the doctor just left and says that my father has urosepsis. What is that? What do you say? Do you say that the urine is in the blood now? What do you think? Is that what urosepsis is? No. Urosepsis is actually a systemic reaction to urine infection leading to overwhelming organ failure, shock, and even death. It carries a high mortality rate and prolonged hospitalization. They say 10 to 30% of cases of septic shock are actually from untreated UTIs or antibiotic-resistant UTIs, maybe pyelonephritis or kidney damage. Now, before you freak out about getting a UTI, let's just know that most UTIs are not life-threatening. It's when we have those other predisposing factors present, such as what we described in the slide of complicated UTIs, which help the bacteria grow in number and possibly move into the bloodstream. This is where it can overwhelm the immune system and cause septic shock. Urosepsis is considered a type of septic shock. Now we're going to move into discussing what are the signs and symptoms and clinical manifestations of having a urinary tract infection. These are considered the most common signs and symptoms of UTIs: frequency, urgency, suprapubic pain, and burning upon urination. Patients will also develop hematuria, where they will have blood in their urine. Their urine will be cloudy and foul smelling, and occasionally you'll have nausea and vomiting, maybe even fever, like a low grade. In fact, if we were to check somebody's vital signs for a patient who had a UTI, what else would we notice besides a fever? Did you mention maybe tachycardia or tachypnea, breathing fast? If you did, that's great. For females, would we see vaginal discharge on a UTI? The answer should be no. Now, if it is a vaginal infection or a sexually transmitted infection, this can cause a patient to burn when it pees, when they pee. So do check the meatus in the perineal area. However, there will be no other signs and symptoms, just the burning if they have a STI. Now, for males, we do need to check the prostate. Can we do that? No, a licensed provider needs to. I would like to review some older adult considerations when they become, when they have UTIs. The first answer there, get my marker again. The first answer right there is that they are going to have vague symptoms of, or a vague presentation of what we see here. However, we will notice they have increasing confusion or unexplained falls. They will have increasing confusion or unexplained falls. Number 2, for older adults, they will have sudden onset of incontinence, or maybe if they're a little incontinent, their incontinence will worsen. This is considered an early sign of a urinary tract infection. Number 3, they will have no urinary manifestations, but the vital signs will change. And what I mean by that is they will have a fever, they will get tachycardic, they'll have tachypnea, and maybe even hypotension. This is actually a very bad finding because this means that your patient has probably already developed urosepsis. Number 4, your older adult is going to present with a loss of appetite, nocturia, dysuria, and dysuria. That is it. Those are considered common manifestations in the older adult. Well, you've noticed that your patient has these symptoms. Oh, now what do you do? Well, it's time for you to write down. A person comes in with these symptoms. What do you do next? Hurry, I'm waiting. Yep. Can I get a urinalysis? Can I get a witness? Can I get a urinalysis witness? Yeah? Okay, well, maybe not. That's what you would do. I like how they use a glass jar. Fancy. Okay, well, let's look and see how to interpret a urinalysis. This takes a lot of practice, and you'll probably need to use a reference material quite frequently whenever you first begin looking at these. But a urinalysis includes a microscopic and a macroscopic report. This is considered a macroscopic report, and here is the microscopic. Okay, so what is included in a macroscopic report? Well, we can take a quick peek to see if our patient is well hydrated or not. And then the next thing we're going to look into is to see if they are positive for nitrates and leukocyte esterate. Well, what is a nitrate? Good question. A nitrate is actually a byproduct of bacterial cellular metabolism. Another way to think of it is bacteria poop. I know, I just said that, bacteria poop. Well, this is a pretty sensitive indicator. If I have bacteria poop, it probably means I have bacteria, but do note that not all bacteria will have this be their metabolic waste. Our most popular, if I can do that, our most popular bacterias will produce nitrate, but not all bacterias actually do. But like I said, it's a pretty sensitive indicator. In fact, nitrates will probably be positive in about 68 to 88% of the UTIs that you come across. Now, how about our leukocyte esterase? Is what I just highlighted down there. These are going to let us know that there are white blood cells possibly that are floating around inside the urine. And so with the presence of both of these, it's a sensitive indicator in the diagnosis of a UTI. When we do a microscopic look, we're looking to see if they have white blood cells and red blood cells and how many. So it actually is going to quantify it for us. And under our microscopic look, if the white blood cells are greater than 3 plus, and if the red blood cells are greater than 3 plus, this usually indicates infection. 3 plus on both of those. Okay. Now occasionally when we grab the urine sample and send it down to the laboratory, the report will come back that we have a contaminated sample. Well, how do we know that? Well, on that macroscopic look and microscopic look, there will be a report of the epithelial cell count, the squamous cell epithelial cell count. That's fancy for skin cells. And what lives on our skin? Bacteria. So that can falsely give us a positive urinalysis. So what we have to do is we have to set a threshold of what is considered an acceptable or contaminated urinalysis. So when we read our reports, look for anything that shows 20 or greater epithelial cell count. If you see that the sample is contaminated, it should be thrown away, no decision should be made, and we need to re-grab that urine sample. Well, let's just say that we did see positive nitrates and leukocyte esterate, white blood cells and red blood cells. What do you do now? Because it says maybe 0 or 5 epithelial cell count. Well, then we're going to proceed to do a culture and sensitivity. The culture is going to actually identify the microorganism, and the sensitivity part is going to let us know which bacteria we should choose. When we do a culture, we are looking to see if there is greater than 100,000 colonies that are going to be on our sample. That can actually confirm a positive UTI. Now, what will a UA show up if our patient just has a history of interstitial cystitis and they come in complaining of all of those signs and symptoms that we described a couple slides ago? Well, their UA is actually going to be negative. Maybe it will show some white blood cells, but it will not have any red blood cells and it will not have any bacteria. That's how we know oftentimes that a patient is likely to have the diagnosis of interstitial cystitis. For a true diagnosis, though, they do have to get a cystoscopy. So, more about the culture and sensitivity. This confirms the number and type of organisms and the type of colonies. It is considered expensive and takes about 24 hours to get a result, but it is indicated. It doesn't, and it's really important because a lot of times we can understand if a bacteria is not responding to therapy, meaning the patient is not getting better. This will help us make a better decision of what to do next. Another indication for a culture sensitivity is when we are treating a patient who is of advanced age. Maybe they have a complicated UTI, and we need to definitely ensure that proper antibiotics are prescribed. So when do we do a complete blood count? The complete blood count is important because we are going to look at the white blood cells and we're going to expect to see an increase in the white blood cells. In fact, I'm going to teach you a new term called a left shift. A left shift typically means that there are more band cells in a complete blood count that is drawn with a differential. I personally think of band cells as white baby cells. In fact, if the body is producing and mobilizing a large number of new white blood cells or band cells, and the body will begin attempting to fight off a very active infection. In fact, what it will do is it will start feeling that it's necessary to kick out the baby white cells out of the nest before their time is ready for them to mature and join the fight appropriately. So we're going to see a rise in the band cells, or the white, how I like to say, the baby blood cells, because they're not ready yet, they're not mature, but the body thinks that they need to get them into the bloodstream faster. And we call that a left shift. And a left shift doesn't occur unless it's a complicated UTI and or urosepsis is present. I have an example on my next slide. This is a great example of a CBC on a patient who's developed urosepsis. The differential means a breakdown of more of the blood components. Oftentimes we'll just run a CBC on patients, but if somebody is suspected of having urosepsis, you want to see a CBC with differential. So looking at this patient's CBC, I see a rise in their white blood cell count, and looking at their bands or their baby white blood cells, I see that they're beginning to rise. This is letting me know that the body feels an impending infection, or it's noticing an impending infection, and it is sending out these infection fighters before they are fully mature. Oh, yes. Well, we have a patient who is confused, who's their older adult, maybe they have dementia, and we are suspecting that they have a UTI. Well, let's grab a urinalysis. Oh, it shows no red blood cells, no white blood cells, but it does show bacteria, but there's no symptoms. So other than the confusion that was sort of already present to begin with on a good day for your patient, so do you treat it or do you not treat it? What do you think? Let me show you this video, and I'm going to move the mouse. Yes. No. Okay. You know what? I will post the answer with this video in the module, so you will be able to see what the answer to that previous question was. Where I would like students to start is at 1 minute and 26 seconds. Good times. So you want to know the answer, you better open up this video in the module. So what are some of our other diagnostic tests that we're going to do for this patient? Well, a UA is usually all that you need. However, if retention and obstruction is suspected, we can do a pelvic CT. A pelvic CT. We can also do a renal ultrasound or a pelvic ultrasound. We may need to do something called a cystourethropography. I'm going to try to say that again. Cystourethropography. There you go. That's if urine reflux is suspected. Usually there's some anatomical problem not allowing the urine to come on out. We can also do, and a short little snip of what this procedure is they will insert dye from your urethra. They'll insert a catheter, they'll insert it up, pull the catheter out, and then they're actually going to watch the patient under fluoroscopy urinate, and they watch it go down or not go down, really. So that is a cystourethropography. Then we have a cystoscopy. This is the only way that we can truly diagnose interstitial cystitis. We can also see if there is bladder diverticuli, like little pouches inside of the bladder, or if there is trabeculation. This is also known as wall thickening from constant urinary retention. So we can do a cystoscopy. We can also do a retrograde pyelography. This is where dye is going to be inserted up into the kidneys, so the kidneys are actually not going to have to filter the dye, but it will be inserted up, and then using a catheter from the urethra into the bladder all the way up the ureters, and we're going to watch the bladder, the urine as it drains all the way out. So if dye is administered into the kidney, is this considered okay? And the answer is it is okay. It is considered safe because the kidneys are not actually filtering it. It's coming from the bottom up rather than going in their blood where kidneys would be filtering it then. Prevention. This is so important. So do you remember how much liquids our patient has to drink? About 64 to 100 ounces per day. And that's if there's no contraindication. This means your patient needs to void about 7 to 10 times per day, constantly flushing the urine out of their bladder. Adequate sleep is important because sleep is connected to your immune system. So if they're not sleeping, their immune system is not going to be best. Underwear comes in a lot of different fabric types. However, cotton is considered the best because it is breathable. They don't recommend that there be any scented, say, lubricants, no scented toilet tissue, no scented anything should be used down there. Wipe direction, always front to back. Don't delay urination. If a patient needs to urinate, encourage them to go when they have the urge, rather than hold their urine for so long. This one's a very important one because sex can lead to UTIs. The perineum should be washed before and after intercourse. In fact, we usually will coach our young females who come in who have frequent UTIs to pee immediately following intercourse so they can flush any bacteria that may have been transmitted from one place to another. Another recommendation is that if a female is going to participate in anal sex, they say that there should not be anal to vaginal sex. It should go the other way around. Okay. Early reporting of signs and symptoms is important, and some homeopathic interventions. In fact, there it is. Cranberries are useful in preventing UTIs. They do not treat a current or active UTI. It has no effect on an active UTI. It is only beneficial if cranberry products, and I don't mean cranberry juice, it really needs to be like the concentrate or supplements that's not been sugared up. If they are consumed minimum about 4 weeks or greater, and then they actually can have some protective effect. So cranberry juice can be helpful if consumed greater than 4 weeks. Taking about 2 tablespoons of apple cider vinegar is very helpful every day. In fact, you have to do it 3 times a day. If you ask an older adult, they often default to doing that intervention. Now, some of our patients have low estrogen, such as our postmenopausal patients, and this is a problem because they experience vaginal dryness. So the vagina has that protective bacteria, and if it's gone because it's dry, to do this intervention here is going to be a quick way to restore the vaginal bacteria, which will in turn prevent UTIs. This is another over-the-counter vitamin supplement that patients have been known to take to prevent the bad strains of E. coli colonization. Okay. Well, let's just say that even though we've tried to prevent a UTI, it has occurred. So what do? The first thing we're going to do is drug therapy. And then the second thing is comfort. Let's see if I can get my... There we go. These are your 2 main priorities. For drug therapy, we are going to give our patient urinary aseptics or antibiotics. In fact, the first line of medications are going to be sulfonamides. The one that comes to my mind is Bactrim. Bactrim is a combination drug consisting of trimethoprim and sulfamethoxazole. I know, we'll just stick with saying the word Bactrim. This drug right here is pretty well tolerated. However, we do need to assess allergies prior to make sure our patient is not allergic to sulfa drugs. And if they are not eligible to take this. We also need to inform our patient if they are on a sulfa drug to stay out of the sun and that they can possibly burn easier because this drug causes photosensitivity. And I believe they need to take this medication with food. I have heard of older adults needing continuous low-dose antibiotics, and this is because they have more than 3 or 4 UTIs a year, and we don't want them to increase their risk factor for having kidney damage, so they will put them on continuous low-dose antibiotics. Or if the person is female and of younger age, a lot of times what they'll do is a person will take a sulfa drug just after intercourse. So it's sort of like a prophylactic to a UTI. This one right here is not really used to treat an active UTI. It's just for prophylactic reasons. And low dose. Okay, low dose prophylactic. Okay. Now for comfort, sitz bath. This is where you can buy a little device, maybe at CVS or Walgreens, that will spray warm water on the perineal area. It is very helpful in the pain, usually after somebody urinates. There's a lot of pain, so this can reduce that, and they'll do it for about usually 2 to 3 times a day or more if needed. You can do it more. We can give patients analgesics. The one that comes to mind, it's known as pyridium. Oh, let me think of how to say the other word. Okay, I think I'm ready. The other name for pyridium is phenazopyridine. Phenazopyridine. I believe there's a chart in your book that talks about the analgesic. So for phenazopyridine, you take it usually for 3 days max. It's not to be used more than that, and this will change your urine a very, very bright orange. We're going to encourage our patients to use panty liners or underwear liners because it will stain the underwear permanently. Also, macrobid. I picked the yellow capsule here because this will turn your urine to hot orange too. Nope, hot yellow. Hot yellow. So hot yellow from macrodantin or nitrofurantoin. Maybe I should do this. Yeah, there we go. For pyridium or phenazopyridine. Great. The antispasmodic, the one that is in your chart, known as Anaspaz or hyoscyamine, that is a medication that we can use for if a person has urinary frequency. It is not used very often, but it can be used. Okay. Encourage your patient to avoid caffeine, carbonated beverages, and tomato products. These are considered as irritants to the bladder during this time period. All right, so assess your patient's understanding, such as what does it mean to have your symptoms relieve? We want them to continue to take the drugs, anticipate the orange urine with the pyridium, maybe with a nitrofurantoin to anticipate the highlighter yellow urine. Assess their feelings as well, because they may have a quality of life impairment and feel a little embarrassed because they do know that, well, they understand that we know it was from some sexual activity. In fact, speaking about sexual activity, we want to warn them of the riskier positions and the riskier sexual actions, such as going from anal to vaginal sex. The first blank right there is going to be sexual positions. In fact, when the male penetrates from behind, that is considered a riskier position for UTIs, so they may need to reconsider or do a good perineal cleansing prior to. Another risk factor that they need to consider is vigorous cleaning of the perineum is to be altered. In fact, products that are made to clean the perineum often wash away the protective flora, so we want to discourage vigorous cleaning. Douching is something I'm thinking of. And last but not least, contraceptive preference. Patients who use diaphragms and spermicides may need to consider using something different, such as just condoms or maybe contraceptive pills, because diaphragms and spermicides increase your risk for UTIs. Okay, we are done. Let's just go through our post-quiz questions. Don't forget to pause me because I'm going to click forward. Hopefully this is what you answered. So cystitis is associated with a risk of acute pyelonephritis during pregnancy. This is what increases the risk of preterm labor. Here's your next question. You probably don't need a pause because this is a quick one. So I'm going to go ahead and click forward. Sulfonamides such as sulfamethoxazole are drugs that can cause photosensitivity and increase skin irritation and pigmentation. This means it's going to lead to sunburn upon exposure to the sun. Now, amoxicillin may reduce bacteria in the urinary tract. However, this can lead to diarrhea, not having photosensitivity. Fosfomycin reduces the incidence of cystitis, but it has the side effect of dizziness and vaginal itching. This one down here, cephalosporin. This is a cephalosporin that is likely to lead to rashes rather than skin darkening in a patient, especially if they have an allergy to penicillin. Here's your next question. Please pause so you can read it. Okay, I'm going to click forward. And this is your answer. Adequate fluid intake and frequent urination helps flush bacteria from the urinary tract and thereby prevent UTIs. Washing the perineal area before intercourse definitely reduces the presence of bacteria, and bubble baths may irritate the genital area and make it more susceptible to infection. Flavored lubricants may increase irritation and their risk for infection. Well, that's all I have. The end. Have a wonderful afternoon, and we'll talk soon.